गया यही है ना. I have the whole program.
इसमें इजी रहेगा ना पढ़ने में, खोलना नहीं पड़ेगा.
ये देखो अभिजीत कुछ लिख रहा है.
जाना था ना. एनीवे
Done. तो मैं वेलकम बोलूँगा, आप फर्स्ट स्पीकर को बुलाना. Okay. Can we start? Okay. Yeah. Okay.
या
Okay.
Vidye Amritam Ashnate. May the knowledge of medicine bring immortality to humanity. Happy morning to our honorable faculties, delegates, and my fellow colleagues. Today is a new canvas waiting for your brush strokes of creativity and success. Embrace the possibilities and make it a masterpiece. We are all gathered here at the 47th Annual Conference of the Indian Society for Surgery of the Hand, ISHCON 2024, Bengaluru. This is the first combined annual meeting of the Hand Society of the India, UAE, Australia, and Singapore, organized under the aegis of the Bangalore Orthopedic Society and the Karnataka Association for Plastic, Reconstructive, and Aesthetic Surgery, along with the Singapore Hand Society. This prestigious event promises to be a landmark gathering of the experts and the thoughtful leaders in the field of hand surgery. We have crafted a comprehensive program featuring keynote addresses, panel discussion, workshop, and paper presentation, ensuring a rich and immersive experience for all the attendees over the next 3 days. We are delighted to host the historic convergence of hand surgery specialists from across the globe and looking forward for the meaningful collaboration, exchanging ideas, and advancing the frontiers of hand surgery. Thank you once again and welcome to ISHCON 2024 Bengaluru. Before we proceed, I would like to take a moment to welcome you all to the conference at the Galaxy Hall. To ensure a seamless experience, please note the following. Our preview room is available for your convenience where you can upload your presentation to the conference computers. A technical team will assist you with any requirements. We are also proud to acknowledge our local trade partners who have made this event possible. Additionally, I would like to bring to your attention several important components of the conference. Firstly, we are excited to announce the Breaking Boundaries in Healthcare workshop scheduled to take place in Galaxy Hall. We are pleased to inform you that a coffee shop by Karnataka's renowned Hatti Kapi brand is available just outside the hall throughout the day. You are welcome to grab a cup of coffee at any time, but we kindly request you to do so in small groups to avoid overcrowding. Now, let us begin a transformative conference experience, which will be conducted from 9 a.m. to 12 p.m. I would now like to invite our esteemed conveners, Dr. Ravi Bharadwaj and Dr. Shailesh Gupta, onto the dais and to introduce the speakers and moderate this enlightening session. Thank you.
A very good morning. And at the very onset, I would like to express my gratitude to the organizing committee for the opportunity. It's indeed an honor. And I have with me, as chairperson in this workshop, Dr. Sailesh Gupta from Indore. All of you know him. So the way it's going to run is a few housekeeping rules. So basically, mobile phones on silent mode. We'll have adequate time for question answer sessions. So the way we've formulated the workshop is we'll have different applications for suture anchors. I'm sure many of them would have already used them, but then many of you would want to know a little bit more about the specific indications and also the principles of using this implant, which versatile implant. So what we'll do is we'll go through 4 didactic talks and with case-based scenarios in each of them. And then we'll have some question answers. Feel free to ask as many questions as you want. And that will also, after 4 talks, then we will go to the wrist, and then we will follow up. There's a talk on elbow suture anchors also. And then we will have a sawbone demonstration at the end of it. And in between, feel free to interact with the faculty during the workshop, ask as many questions, during the sawbone workshop. Okay. So I will now request my colleague, Dr. Shailesh Gupta, to introduce the first speaker and also tell us a sequence of what the talks are going to be.
So our first speaker is Professor Dr. Srinivas Rajappa. He is one of the most analytical speaker I have ever seen. He will give the crisp of that particular subject in a very, very nice and precise, elaborated. Everything will be there in his 10 minutes talk. Srini?
You're able to hear me? Okay, great. Right, very good morning to all of you, and delighted to be here. Thank you, Shailesh and Ravi, for this opportunity, and thank you, Bharat, Darshan, and Vamsi, and the rest of the organizing team for giving me an opportunity to do this talk. It's difficult to open the batting, but I'll still try to do my best. And thank you, Shailesh, for the generosity of your words. And I fondly hope I'll be able to live up to all that. I'm very fond of history because history helps you understand a lot of things. If you look at the history of the cell phone, I'm sure most people here lived in a generation where the cell phone was like a brick. And we are now getting to a cell phone which will probably be smaller, which will be able to do 20 times work as what it was doing 20 years ago. So if you do not know from where you started, you won't know where you're going. So I think history is very, very important. The second reason why you should understand history is that it is important to know the thought process of a process or an implant or what the innovator had in mind. Because at the end of the day, your skill is going to come by doing something, and doing more of something. But if you want to make something new, you have to understand what thought process the innovator had. Somebody in 2007 came up with a phone which did not have a button, which means I do not know how that man envisaged it in his mind. It would have been nice to pick his brain, but unfortunately I can't do it now. So let's look at history. The entire thing was powered by necessity. There was a need to do. Did I press something? Is that okay? Right. So there was always a need for something. So the need only brought out new things. So we know that necessity is the mother of invention. I also found this very interesting quote, but desperation is the mother-in-law of invention. So you try to do things slowly and you try to do it carefully. So very unintentionally, this man on the left side with this, which is Arthur Bankart, he was the one who sort of ignited this entire process of developing a suture anchor. Because in the 1930s, he figured out that when a shoulder dislocated once, the glenoid labrum detached off the glenoid. And when that happened, it made the shoulder susceptible to recurrent dislocation. We all know that. And then they devised an operation where they go and put back the labrum, and the labrum was a piece of flesh that had to be attached to a piece of bone, which is the glenoid rim. And then they were drilling holes in the glenoid rim, and then they were reattaching the sutures and so on, reattaching the labrum. It was working very well. There was no problem with that. But subsequent to that, they realized that the entire procedure was a lot more difficult to do, especially in the shoulder joint. The second thing is it is an open procedure. And the third thing was soft tissue was being attached to bone in many other parts of the body where the importance of ligament detachment and ligament reattachment was beginning to be figured out. So these are the parts of a suture anchor. You basically have only two parts. You have the anchor and you have the suture. But you have three interfaces. So this is the sorry, is the point there? The black one, okay, sorry. So this is the anchor, and this is the suture. You have only two parts in it. The anchor is going to fix to the bone, and the suture is fixed to the anchor. But you have three interfaces in it. You have the bone anchor interface, you have the suture anchor interface, and you have the suture soft tissue interface. Now, all these interfaces will have to have different strengths of pull-out, which means this has to be the strongest, the next strong being this one, and this one being the least strongest of all of them for this to work effectively. The idea is that this holds the soft tissue onto the bone till the bone soft tissue heals, and then that takes over. The first suture anchor was made in 1985. It was made by these two gentlemen, Marlowe Goebel and Carl Sommers. It was called the STATAC. It was made by what was Zimmer. I think Zimmer no longer exists. So it was made of titanium, and it had braided polyester, which is the Ethibond suture. And that was about 4.6 millimeters in diameter. This was the first suture material which was ever made. But very funnily, this was for a long time never used in a human being. They patented it in 1986. But till about 1993, there were no clinical studies on the suture anchor. But in the middle, as the race got better, then this was made. The Mytex suture anchors, which had basically, which was made of nitinol, which is an alloy of nickel and titanium, and you just had to insert it, and then the flanges will open out and it will hold in the bone. Very strangely, if you go to a construction site and see an electrician working it, he's working with a lot of stuff like this. The next suture anchor which came in was the Acufex TAG rod. Again, all these suture anchors basically were fixed to the bone by one of the two principles. Either you screwed them inside, or you just slammed them inside so that there is an interference fit. So these were the original suture anchors. And they did actually very well. Their pull-out strength was fantastic. They were beginning to be used on a very large scale, a lot of clinical experience, and did very, very well. So we could have stopped at that, but we couldn't because there were other problems. So there had to be evolution of, as far as the material which was used in the suture anchor was concerned. Suture materials were getting better. The size had to become smaller. And then we also moved into the era of knotless anchors. We'll come back to that in a little bit. Now, this is akin to the software industry. The microchips got smaller and smaller, and they had more computing power. The broad bandwidth was getting better and better, and one was fueling the growth of the other. There was just a need to do better things. So, was everything okay with the metal anchor? The metal anchor was fantastic. We still use it, still a very good thing to use. It was very strong. It had a proven track record because metal anchors are basically small screws and extensively used in orthopedics. And radiographs could be used to assess their position, which was a big advantage. But the problem was, it was not MRI compatible, at least for some time. There were difficulties in revising it. Say you put a suture anchor in the wrong place, you take it off, you have a huge hole there, and you can imagine what's happening to a 4.6 millimeter anchor or a bigger anchor. And whenever it got displaced from a joint and it jumped into the joint, you have a potential for arthritis. So you needed something better. And welcome biodegradable polymer, which is, again, something we know, which is what is there in Vicryl. Polyglycolic acid and polylactic acid. It sort of negated the disadvantages of metal in some ways, less chondral damage, it was easy to revise, it was MRI compatible, but it also had problems. The problems were that it was beginning to produce a lot of reaction with cyst formation and sterile discharges and so on and so forth, and definitely less fixation compared to metal ones. There was less osseointegration. So again, as I mentioned, this problem gave rise to this solution. So they put in a different material, which is a different polymer, PLLA, which had longer degradation time. And then it also, they incorporated some amount of tricalcium phosphate in it because the osseointegration had to be made better. Now the development of the suture anchor was, the anchor part of it was getting better, but somebody made a better suture. Now traditionally in all the suture anchors before this, the problem was the junction between the suture and the anchor. So that was always snapping, the suture was not strong enough. Till somebody came and made ultra high molecular weight polyethylene, which is actually fiber wire. So when fiber wire was introduced into the suture material, it actually became the strongest part of the suture anchor. It could even pull off the suture anchor from the bone because it was really, really strong. So there was a need to make the bone anchor, the interface, much stronger than what it was. So how could you make that? You can put metal in it, but we also spoke about the problems of metal. So they moved on to making absorbable metal anchors, which will stay there for a long time and have all the advantages. And make absorbable polymer, the PLLA one, much stronger. And also use what is called a PEEK. Now what is PEEK? PEEK is again a non-degradable polymer, which is polyether ketone. But the problem with the PEEK was it had less osseointegration, there was breakage of the hyoid, and there was a lot of cost. And then we started doing it. As hand surgeons, we were dealing with the lunate and the scaphoid, and those are much smaller bones compared to the shoulder. So we needed the micro and the mini anchors, and the mini anchors sort of started coming in because the original experience in suture anchor use in the wrist was using the same shoulder anchors, which was blasting the lunate off. So you had to use smaller suture anchors, and that gave rise to the mini and the micro. The Mitec and the other anchors were the ones which were holding the sway as far as this was concerned. Now, there was arthroscopy on the other side was also pioneering or powering the development of much better suture anchors. Arthroscopic knot tying, I confess here that I do not have any experience with arthroscopic knot tying, but anybody who has done it says that it's a very difficult job to do. So somebody said, just throw away the knot, you don't need the knot anymore. So that gave rise to knotless suture anchors. So there are two types of knotless suture anchors. You can attach a suture to it, which means this is a TFCC repair, where they put fiber wire inside, you bring the whole thing outside and you just attach it here. You don't need to tie this knot or anything like that. You put that fiber wire inside this eyelet, you push it inside and you just cut it off. The second thing which could be done was you can insert tissue inside it and also fiber tape. Now this is a picture of a scapholunate ligament reconstruction where a fiber tape along with tendon graft has been put there, and you can use a suture anchor to just slam it inside. You don't have to tie anything. So that's what sutureless anchors did. And then somebody said, you don't need any suture at all. You can just make the whole thing with something smaller, something softer. And that was the genesis of the all suture anchor. The all suture anchor was basically low profile, it was soft, it was easy to insert, and it just took off all the problems of the metal or the material in it. So how does it work? Sorry, that must have been before. Oops, can you do that? There is a video to be played in that. That one, yeah. So this is how a all suture anchor works. It has no metal or any material in it. There are no hard parts in it. Everything is soft. So you just push it inside, and then you pull it, and then it bunches up and it just stays inside. And it sort of alleviates all the problems of metal staying there and so on and so forth. So that was the next development in suture anchors. So in summary, you need to know that there was a need. The development of the suture anchor was pioneered by a need to attach soft tissue to bone. It's important to know the parts of the suture anchor is basically suture and the anchor. The anchor can be moved from metal to bioabsorbable to biocompatible, and now no metal or any part of the anchor. So there is braided polyester, which is now becoming the gold standard, which is the fiber wire. You also gotten on to knotless suture anchors, which are of two types. One is the suture first and the tissue first, and then you have the all suture anchor where you don't need any material on the anchor at all. I also take this opportunity to invite you to the hand course we are doing with the ISSH. This is on the 13th and 14th of December. All of you, please come. It will be a very good learning experience. And also this one, which Ravi is conducting along with Anirban next year at Calcutta. And this will also be fantastic, I'm sure. Thank you so much.
So thank you, Srini. And as you said, the necessity is the mother of all invention. I would add to that, luxury nowadays is mother of necessity and then becomes a mother of invention. So thank you for nice and brief introduction of the suture. Next I call upon Dr. Parag Lad from Bombay. He'll be talking about jersey finger, can suture anchor improve the outcome? So after the 4 lecture, we will have a question answer session, and then we'll again have a some lecture, and then question answer session, and followed by Sorbonne workshop.
I thank organizing committee for this opportunity. Just to brush up our knowledge about jersey finger, that is FDP avulsion, that type 1 is avulsion of a tendon and the tendon gets retracted up to the palm. In type 2, the avulsion of the tendon is up to the PIP joint. Type 3 is the large avulsion fracture fragment and retraction of tendon up to the DIP joint. And type 4, there is double avulsion. There is a bone also is avulsed and the tendon is also avulsed up to the palm. And in type 5, there is a comminution in the distal phalanx along with the avulsion fracture. So indications to use suture anchor in jersey finger injury is preferably only tendon avulsion. I mean, if there is a small bony flick, we can still attempt to do it, but we need to have a good amount of distal phalanx base shaft to put the anchor. And it can be used in tendon reconstruction, like in chronic cases where we attach a tendon graft to the retracted FDP tendon. So this is a clinical case where classically the flexion at distal interphalangeal joint is absent to test the flexor digitorum profundus action, and this confirms either on dynamic sonography or a MRI report. And nowadays sonography is a very good modality of investigation in chronic cases where we can identify the retraction of proximal end is at what level. Especially the surgery is performed as per standard Brunner's approach depending upon your retraction, and this is how we identify the avulsed FDP, which has, in this case, it has avulsed up to the middle phalanx. And then whatever anchor or pull through button technique, whatever you do, you must identify or maintain a proper A4 pulley passage, because unless this pulley is intact, and there should be a free gliding of the tendon. So the pulley has to be made completely free, especially in little chronic cases. Then we should retrieve the tendon. There are various methods to retrieve the tendon. You can take a Prolene stitch at the end of the tendon and just pull the Prolene stitch. Or nowadays we have a tendon passer which you pass through the pulley and then get the tendon. But try to preserve at least 2/3 portion of any, the shaft level pulleys. So this is the retrieval of avulsed FDP tendon. Okay. So there are 2 types of anchors at present available. For distal phalanx shaft, we should have, we have options like 1.3 micro anchor or a 1 millimeter anchor. I don't support any company, but these 2, this is a anchor, and they usually come with the drill bit. And the size of the drill bit is exactly where your anchor is going to be placed. So this is one anchor that is available in the market, and this is another anchor. So there is a drill bit. Look at the tip of the drill bit. It will go into the distal phalanx shaft, and then the anchors usually have, some anchors we rotate like a screw, but in the fingers, these 2 anchors are available where you have to either push hard or just tap with the small hammer. So these 2 types of anchor, 1 mm and 1.3 mm anchors are available. Then if you see carefully, there is a small drill bit, a small drill hole. You have to do it under CM. As per the literature, either the drill hole has to be, oblique into the shaft or transverse into the shaft. I will show in my post-op X-ray. And then you have to, once you drill it, you have only one chance in these cases, because if you make a bigger hole, these anchors become very loose, and then if that becomes loose, you have to go into the conventional technique, like a pull-through button technique. And then as these anchors, we cannot screw them, you have to tap very gently with the small hammer till you hear a noise, and till the tip of the, the anchor is, and then the tip of the anchor is into the bone. And then they have a fiber wire, and that you have to repair the tendon with tendon technique. And then you have to pull back the A4 pulley again, because to avoid the bowstringing effect. The closure of the A2 pulley is important. It all depends on at what level you are doing the repair. The position of the finger has to be maintained well. So somebody, your assistant has to hold DIP joint in desired 20-degree flexion to repair the FDP tendon, and then repair the pulley. The cascade of the finger has to be maintained very well. The result, this is the X-ray, and make sure that here the point I would like to explain is your anchor placement has to be little, at the finger, distal to the insertion of extensor digitorum communis, and it should be distal to germinal matrix, because sometimes if the anchor is little longer, then it may irritate the nail bed, and it can cause a bad irritation to the nail bed, and I have seen the nail growth is also hampered. So you have to be very careful about it. So this is the 7 weeks post-op, still under rehabilitation, but usually because we go little slow, at around 10 weeks later we can start the passive movement, and they can get a good movement into the DIP joint. So another case that I would like to explain, so that was the acute case, and in chronic case also, like in this case, the quality of, this was a 3 months old injury where the quality of flexor FDP tendon was bad beyond the middle phalanx, or beyond the, in fact, from this level. So after repairing a pulley, then we made a tendon graft and fix it with the anchor, same anchor, and that is how the position of anchor on the X-ray, and they can get a reasonably good outcome. In my experience, I have seen there is 10 to 20 degree extension lag at DIP joint, but they do get active flexion. So functional deficit is very, very minimal. The contraindications to use anchor is comminuted fractures, and plus if the shaft of the distal phalanx is too narrow, then you should not use anchor, and you have to go, these fragments are sometimes largely fixable with the 1.1 mm or 1.3 mm screws, and if you find any comminution on exploration, then the technique you may follow is excise this fragment and then do the pull through button technique. So I usually don't put anchors if there are large fragments or a comminution in the distal phalanx avulsion fractures. The another conventional technique, just to compare the result, is pull through button technique, and usually of course I will show you the reference like from the literature review. So even these conventional methods do get excellent outcome, and so this is the result after doing a pull through button technique. Okay. So here also I have found 10 to 15 degree extension lag sometime remains in these patients. So at 12 weeks there is no difference in terms of the strength, there is no difference in terms of the range of movement at DIP joint, and return to work there is no difference. What we have found, if you put a suture pull through button technique, the taking care of the finger remains difficult if there is any implant outside. The best use of the anchor, once you close the wound, there is nothing to protect. They can take shower, bath, everything. And because there is no, button on the nail bed, or no sutures or no wires, return to the activity at early level, like a typing or, daily routine activities, they are very easy if you use the anchor. Otherwise, in terms of the result, practically there is no difference after 3 months of your surgery. The conclusion, long-term results are the same in both technique, anchor or any conventional technique, and nail-related complications are less if you use suture than pull through. But pull through button technique also nowadays we know our techniques are refined, so we don't see much of this complication. Of course, anchors, they are expensive, and care of the digit is easy if we use a anchor. Thank you so much. Yeah.
Thank you very much, Parag. That was a very nice demonstration.
Thank you.
We'll have questions after the first 4 talks,
Sure.
so our next talk. So I think now the next speaker, I'd like to invite Dr. Arya Roy. Dr. Arya Roy from Kolkata. He's going to be speaking on central slip avulsion.
Good morning, all. Okay, so please change it from beautiful talk on Jersey. Let us move on little proximally. So this is it. This is a boutonniere. Okay, in terms of hand surgery, a boutonniere is just a defect. It is a rupture of central slip, and when it proximally migrated, there is a big defect in dorsal aspect of the PIP joint, through which the proximal phalangeal head can protrude like a buttonhole and creating a boutonniere deformity. So problem is very annoying. Whenever you are trying to reach something, you cannot extend it. So instead of holding it, you are pushing it. So this is absolutely, it's a nuisance, and we have to treat it nicely so that now we can correct it as soon as possible. So diagrammatically, if there is a rupture of the tendon, central slip, it migrates proximally, and the lateral band is migrated below the center of axis of the PIP joint, causing a boutonniere deformity. What are the options? There are actually 3 options. So if you have a proper tendon stump, you can repair it. If you have a big chunk, you have a lot of different techniques how you can fix it. But when there is problem about all these things, there is a very tiny fragment or lacerated stump, what should be done? In these cases, I'm talking about central slip repair, repair using suture anchor. So in this talk, the scope will be using the anchor in the central slip rupture, whether it is valid, its indication, contraindication, reliability, and methods. So we need 3 things: secured fixation, minimal dissection, and adequate strength, so that we can have function as fast as possible. So for doing that, what are the indications for suture anchor? Inadequate stump of the proximal part of the tendon, if it is lacerated, if it is having very tiny fragment which you cannot, it is not amenable to fix, or there is comminution. So in these cases, we can think of anchor. Biomechanically saying, the requirement for central slip fixation is to withstand 15 Newton during postoperative rehabilitation and 59 Newton, around 59 Newton during forceful contraction. As Dr. Rajappa said nicely about the failure, this happens mainly in 3 areas: the bone anchor interface, the suture and the eyelet, and not failure at repair. So there are in vitro studies where they have used fresh frozen hands, and they secured the distal phalanx in a servo hydraulic machine and ramped tensile loading until it fails. So it is seen there that the mean failure load of the isolated anchor was 400% higher than the tendon suture anchor complex. It indicates the weakest link of the system is not bone anchor surface, rather it is tendon suture anchor complex. So anchor pull out is just 5% in this study. So another in vitro assessment was there. There the author said that there are 3 types of anchor insertion. So if you put 45-degree antigrade, perpendicular, and 45-degree retrograde, so 45-degree retrograde insertion is more mechanically favorable for a pull-out failure. So Dr. Schroeder et al., there is a wonderful study he did. He is saying that according to that Dr. Barkhart's paper, the failure load is almost same in all 3 groups. But if you doing a 45-degree retrograde manner, it is actually the gap formation is least. Having said that, we can say that mini suture anchor provides enough strength for early short arc motion, which is approximately 2 to 10 Newton, but it may not be adequate for forceful contraction in that period, which we don't require. There is also paper supporting the chronic boutonniere deformity using this anchor, and there is fairly good results. So here is a case. We can see there is a PIP joint volar dislocation. And you see, whenever we got the case, we reduced it nicely and kept in extension. But when we were studying this for the surgery, we consider this is not amenable for fixation or repair. So we chose mini suture anchor. This is a 1.3 anchor. Given there is a small drill bit that we can use with a stop, as Dr. Ladd already showed that. So see, there is if you explore it nicely, we will see there is almost nothing that you can fix with. So here we use that 1.3 mm anchor in a 45-degree retrograde manner, and we got a fairly good result. Although there is a little bit arthritic changes, the patient is not having any issues. Another case, it is Ravi sir's case. This is a sports person, young female, and on exploration we found that there is a bony avulsion. And here you see we did perpendicular insertion of this screw. So this is the pre-guided drill bit, and there is a stop, and we are pushing it perpendicularly. We actually don't use the tapping, we use it give small pressure, and the anchor is stuck in there. So result is fascinating for this thing. So what are the red flags? Of course, it is repeatedly we would say this, so we have to remember the red flags first, then you consider it. So that is presence of infection, no. Fracture at insertion site, not possible. Severe osteoporosis. So in these cases, we should avoid suture anchor in all aspects. So of course, this is, having said that, we would say that this is a reliable method, quick and easy, minimal soft tissue dissection which we require for it to avoid stiffness in postoperative period, and it provides adequate strength for early short arc mobilization which we require. But the most important thing is case selection, and that will be discussed very in a proper manner in our upcoming 7th annual Indo-US Hand Surgery Conference. We invite you all. Thank you very much.
Thank you, Arya Rai. Now I invite Dr. Kiran Latkat from Mumbai. He will talk about one of the most common use of anchor, that is in ulnar collateral and radial collateral ligament repair of the thumb MP joint.
Yeah, good morning everyone, and thank you moderators and the team ISHCON 2024 organizing team for giving me this opportunity. At the outset, the topic is suture anchors in the thumb MCP joint, ulnar collateral and the radial collateral. But the commonest use of suture anchors has been with the ulnar collateral ligament in all likelihood. Because radial collateral ligament per se injuries are known, but they are very innocuous and they self-heal well without much intervention also. So that's a caveat. And there's a couple of case examples very similar. And use of suture anchors per se for ulnar collateral ligament is more in kind of acute or semi-acute cases, relatively fresh. When it leads to the chronic stage, then it becomes the part of reconstruction, wherein the use of suture anchors goes to the next level, what the knotless suture anchors or the reconstruction with a tendon graft, which was mentioned by Dr. Rajappa in his first talk. So directly going to the case examples, wherein this is the first case, and in our even general orthopedic and hand surgeons must have seen innocuous looking injuries where patients do present at a somewhat later stage in weeks or couple of weeks time, when they start feeling pain onto the ulnar side of the thumb MCP, and then gradually they start feeling the difficulty in pinching activity, particularly the tip pinch and the fine pinch when they start getting pain in. And that's where they present to us. This is the kind of laxity what we clinically get. We assess it in thumb in extension and thumb in around 30 to 45 degrees of flexion. If you get this laxity on the ulnar collateral, this is a clinical telltale sign that it's either avulsed or it's torn mid-substance. And this is another video, or rather similar one. Yeah. This was on exploration. We take a lazy S-shaped incision onto the ulnar side, and this is the collateral ligament substance which was avulsed from the phalanx base, proximal phalanx base, which I could locate. There was no Steiner lesion per se. Steiner lesion is where the collateral ligament, avulsed collateral ligament, which gets superimposed, or rather adductor aponeurosis, it comes out, the ligament comes out of the adductor aponeurosis, and the adductor aponeurosis avoids healing or self-healing of the ligament substance. In this particular case, this is the zoom-in picture, and this is the footprint on the right side, wherein the footprint is shown onto the proximal phalanx base. Now, there are multiple options, as Dr. Parag had mentioned. Herein, I'd used 1 mm mini all suture anchor. There is metal anchor also, which has been known for the case descriptions. And obviously, as Dr. Gupta sir had mentioned, luxury is the mother of necessity. So wherein the patient is affording, or there is a possibility then only, otherwise the routine ligament to bone healing also can be attempted, and with the pull-out button. But obviously the anchor gives you that advantage of without any implant or button on the external surface, and everything inside out. So this is the all suture mini anchor which I have used. Coming to the video presentation, the footprint of the collateral ligament onto the proximal phalanx base is around 1.25 or half-inch dorsal and half-inch distal to the articular surface. That's the area where marked, that's kind of isometric axis of the collateral ligament attached. We gently tap it, and it has a self-drill guide, what Dr. Parag had mentioned in his slide. We drill it and gently tap. These are the 20 non-absorbable sutures loaded to the anchor, and they come with the very fine needles. That's the advantage of using this anchor, what I've found. As we tap back the attachment of the anchor, we slide those two non-absorbable sutures, and then we assess the pull-out strength. Theoretically, what the literature of this anchor mentions is that 26 pounds with the 20 suture material and 20 pounds with the 30. 30 fiber wire suture we don't have available here in India. It comes with a 20 non-absorbable max breadth suture. Now with these two loaded needles, we take bites in a Krakow manner which is described. But for this very thin ulnar collateral ligament, taking a Krakow suture is a big task. And if you have a good substance, you can take 2 or 3 wire spirals of the Krakow stitch and pull down the ligament to the footprint. This is the function at around 1 year. Good range of motion, but now that's a kind of subjective assessment. A well-healed scar, and this is the movement what he gets. Especially what patient mentions is they have good painless pinch activity, which is very crucial. Now, he is into that diamond business, so he has to assess those diamonds in a minute manner under those fine lenses. So holding a diamond into the pinch is very crucial for him, and that's where he gets that advantage of repairing the ulnar collateral. And with the suture anchor, he has done well. Similar case scenario in the second patient. Now here on the radiographic assessment, just for the knowledge of the graduates or the fresh residents. Now this is what we see under the X-ray. We have opening onto the radial stress, whereas on the ulnar stress, the opening is not well seen. So ulnar collateral ligament is gone. That's in flexion. The volar and the dorsal capsule is intact in this case. It's purely the collateral ligament injury. This lady had a very trivial injury while getting up from the bed. The thumb got twisted under the trunk, and that's how she sustained the injury. This is the aponeurosis, which was intact, no Steiner lesion here. This is the avulsed collateral ligament. And with this, I could assess that I could get back to the footprint. This is what I wanted to highlight here on the X-ray film, that this is the footprint on the proximal phalanx base. In all probability, or most commonly, it is onto the proximal phalanx base from which the ulnar collateral ligament gets avulsed. Very rarely, what we have seen is it avulses from the metacarpal head. Similarly, here I've used 1 mm all suture anchor, and this is the function she has got around 9 months of duration. Another just next case which I want to briefly highlight. When you have good bony fragment, it does heal. Now, this X-ray is particularly of February 2023, where there was a good bony piece here. Whereas in July 2023, the bone healed very nicely. We just maintained and so treated it non-operatively. So with those fine bony flakes, if the bone fragment is sizable, and patient chose conservative management. So here, the use of suture anchor or the repair is not advisable. This was just a case put up to highlight this point. So take-home point is use of suture anchors in particularly thumb metacarpophalangeal joint is basically for fresh or relatively subacute or semi-fresh cases, and wherein good collateral ligament avulsion is seen from the proximal phalanx. And now, if the patient demands particularly, and he doesn't want any implant outside, the use of suture anchors is very handy. Otherwise, other options can also give you the good outcome. I thank you for everyone for patient listening. Thank you.
So be there, and I invite the previous speaker Parag, Srinivas, and Arya to come on the front side, and let's face the audience, actual audience, what they want to bombard.
So we've had an introductory talk on the principles of suture anchors, and then we've had 3 clinical applications in the finger. So we've had a jersey finger, central slip, and in the thumb, ulnar collateral ligament. So any questions to any of the faculty? Yes, please. Please use the mic. Yeah.
So I have 2 questions. One, something about how to, there are some tricks for tying knots. So is there any trick you want to suggest, because there is this problem of loosening and you have to hold it with some mosquito or something, and then you might end up getting the suture damaged. So is there any trick about this thing? And another question is, with a bony fragment, still you suggest anchor or not? Because, and how you negotiate the thread through it?
Your first question is, it all depends on the quality of substance that you have at the proximal end, to take the stitch. But the simplest is, sometimes the tendons are friable or not a good quality tendon, then we may end up in shortening and or more flexion deformity at DIP joint. So the best is, once you put the anchor, take one thread through the tendon substance. The anchor has got 2 threads with needle. So get both the threads like we do in a modified Kessler. You come from within, inside, out. And then ask your assistant to hold in flexion the joint, and you have to step, hold your knot with the mosquito forceps and tight as early, as tight as possible. But once you take your first knot, then you see how much flexion is achieved and gently try to extend. Your free gliding of tendon is happening through the pulley or not. Because if that is too tight, then you may have to revise. So
yeah, that's what. So is there any trick to not to use the mosquito part? Because
you can use a plain Addison tooth forceps. Plain Addison forceps, not the tooth forceps, to hold it, to hold the non-tooth, plain forceps. Yes. And the second is about the bone. So if your fragment is large enough, try to fix it, because bone to bone healing, everybody knows it is much better than a tendon to bone healing. So if the bone is fixable, you can use 0.6 mm, 0.8 mm K wires and try to fix it. That is one way. But if you feel it is just a piece of wall of the bone or a cortex, then once you put the anchor, you can use 18 number needle, pass through the fragment of the bone, and then you pass your fiber wire through that needle. But don't try to take the stitch of the, don't try to use the needle anchor to go through the bone. If you use it, you have to be very gentle, otherwise the bone will split. It is
and the
very
first knot you take 2 throws or 1 throw only? What you suggest? Because otherwise, if you have to revise 2 throws, it will become, you can't take it out again.
1 throw.
Yeah.
But you have someone else pressing the bone fragment to the fragment, and then use the same principles of using a non-serrated to hold the knot and then tie.
So there is no trick to tie the knot, because the surgeons usually they have that trick of tying, that holding. I don't know.
I have done. You can try a surgical knot also. That is also very strong.
Yeah.
But ultimately, surgical knot, once you take it, it is very difficult to undo it. If you take a simple 1 throw knot, it is very easy to undo it with your forceps.
Apart from that, that is also not advisable that you take a good part of tendon, you go more proximally and you tighten it very much. So it is better to have all the armamentarium ready apart from anchor. So if you have those issues, you can just discard it and you do in another way.
As we talk about the implant, suture, everything, we forget about the good assistants. Choose the best assistant you have, because it looks so small, but it is not. So if the assistant knows where to hold it and how not to crush it, that is also important.
I get your concern, because when you sometimes hold it with a serrated artery forceps, and as Sailesh mentioned, you need to have a very good assistant. I try to do 2 things. One is drop all the instruments and tie the whole thing with the hand. It is a really worthwhile practice. You can do it with your shoelace. When you're not having enough in theater, you can do the knots. That's a good idea. The second thing is you can borrow a little bit from microsurgery, because in microsurgery, when you do a vessel repair, sometimes you sort of get the knot down. The knot is loosening up. So what you do, you pull one knot nicely and then pull the other one gently down. You don't need anybody to hold the knot for you. So that's a good good trick plus tip. It's a trip. Okay, so you can use that. You don't need anybody to hold that.
Or you can just put a dorsal block wire in flexion for, till you take the knot.
If at all you have a bony fragment, then only you can put a wire or...
No, dorsal block is into the head of the middle phalanx.
Yeah, you just putting a this thing. And another question was that if you are negotiating it through a bony fragment, a big, maybe, because is it advisable to use a suture there or not? And another thing is, if it is advisable, how you negotiate that thread out and tie it?
So he's talking about the big bony fragment, and if you are using anchor in big bony fragment, how would you fit the bony fragment and simultaneously pass the anchor so that it compresses the bone fragment to the footprint?
Yeah.
Technically, if there is a large bony fragment, that means the cortex of the distal phalanx will be very thin, and I will not use anchor in that case.
So it is not advisable in a large, so better to use a wire or something. Yeah. Thank you so much.
Yeah, and then additionally pull-out button. Pull-out button is always the savior. Whatever suture material or suture anchors have come out, but pull-out suture material doesn't like it. Yeah.
Sir, tips to remove misfired suture anchor from the phalanx. My name is Harshal Kaladia from Rajkot.
Misfired.
Tips to remove misfired suture anchor from the phalanx for thumb UCL reconstruction, for example.
Lot of prayer.
And
Fortunately, I've gotten away from the metal anchors and I've used these suture anchors. I have been still safe. So no experience on that.
So you may just push it inside more and cut the thread. Yeah.
And for central slip chronic cases for Buttigieg deformity, how to balance the volarly migrated lumbricals, lateral bands?
Okay, you need a total different approach for that. Only in fresh to little older cases you can use, but I have no big experience on chronic Buttigieg deformity, so I would say that there is different methods for it, so better you use that.
If I may answer the question, for chronic Buttigieg deformity, you could do transverse retinacular ligament release, and then you can flip the two flaps of the transverse retinacular ligament on either side, bring it to the top, to the dorsum, and suture it together, which will bring the lateral bands, the conjoint bands, more towards the dorsal axis, dorsal to the PIP joint rotation. I've used it in a couple of situations. It works well, but you need to have a very good hand therapist at your disposal for this to work. Otherwise, patients will stiffen up.
So, anyone in this FDP, Bipin from Bombay, FDP avulsion, anyone experience about the stiffness of the DIP joint? And it's like how many of you have got stiffness and how many of you have got good range of motion? Because most of them turn out to be stiff many times. Yeah.
So, you know, the moment you repair the FDP tendon, most of the times we get a feel that whether this joint is going to be stiff or it is going to have a better result or not. There are three things according to me. First is how your FDP repair site glides underneath the last pulley. Okay, and you may have to sacrifice A5 and you know, the first thing is gliding. So I have encountered stiffness in almost all because of the fear that if I start my mobilization too early, it may break. So for 2 to 3 weeks, I just wait and I start active flexion, you know, and no passive extension at all. And the first is gliding, second is the bulkiness at the repair site. It all depends, you know, that will also. And the third thing is, in my opinion, if we are not able to fix the bony fragment, and if I find it very much comminuted, I just excise them. Because if I excise the bony fragment and repair the tendon with anchor to the bone, then the bulk around that region becomes little less, and that gives better mobility according to me. So the stiffness is bound to happen. More like a stiffness, it's extension lag probably. You know, they don't have full extension in my experience, at least up to 3 to 4 months. After that, the long-term follow-up is difficult. They don't come if they are better.
So another question is that if there is a small fragment which is not much displaced, should we really open this area? or
And
should we
how
not?
will you fix it then?
Not fix it. So, what do you think?
May I answer?
Yes, please.
If the fragment is small, it is still undisplaced, then it has to be a very careful, supervised follow-up and decision that every 4th day, 5th day, you get an X-ray, assess whether it is not displacing. If the moment it displaces, you go and fix it. If the patient doesn't agree for it, don't let it go somewhere else. Let him go somewhere else. This will be my way of doing it. Otherwise, in the anticipation, I will operate that. So in the anticipation, I am going to die, it doesn't mean I should die now only.
After fixation of the anchor to the tendon, should we immobilize the joint with a small temporary K-wire for a few weeks and then start mobilizing, or can we immobilize it earlier? What is the protocol to be followed?
It all depends on how the compliance of the patient will be. Whether the patient stays in your vicinity and he will be able to keep a follow-up with you regularly. If he is not able to keep a follow-up regularly, then it is better to immobilize or put a dorsal block wire for 2 or 3 weeks. By that time, we are very sure whether our repair becomes little robust. But it all depends on patient's compliance and how particular he will be to keep a follow-up with you. But otherwise, it is not compulsory to put a wire once you repair it properly.
So at what stage would you mobilize, for example, in a FDP avulsion with a suture anchor, where you have just used the anchor?
So active flexion will begin within 3 to 4 days practically, and there will be a dorsal slab till the nail tip, nail bed, up to the nail. So I will make sure that the passive extension by any means will not happen beyond 20 degrees. The patient's DIP joint of the finger will remain in flexion, but active flexion at MCP, PIP will just begin within 2 to 3 days.
That amount of millimeter or two of tendon glide to make sure you don't get any adhesions, but at the same time there has to be some protection so that it doesn't go into extension passively. So there has to be a dorsal blocking splint all the way up to the nail bed, like Parag said, and then active flexion you can start as soon as the swelling subsides in 48 to 72 hours.
Yeah.
That's what most of us would do, yes. For collateral ligaments, what would your rehab protocol be?
For collateral ligament repair, we'll give a thumb spica splint for a couple of weeks for the wound and the tissue to settle down. And then at least the thumb flexion extension you start with intermittent splinting. The pinch and those strength measurements will start somewhere around 6 weeks.
Okay.
Sir, this is Dr. Tyagarajan from Coimbatore. A question to the person for the central slip. What is your rehabilitation protocol, and have you had any recurrence of flexion contractures in your late follow-ups? And in the early period, during your rehab, do you immobilize it with the K-wire or a splint and move only the DIP, sir?
I use a K-wire through the joint for 3 weeks, but at the same time, I use the DIP joint movement so that the tendon is gliding. After 3 weeks, I remove it and start early mobilization. That's it. That case I showed, I did the same, and all cases I do same, almost same. Of course, there is difference in case scenarios, and according to that we change.
Dr. Shijin from Thrissur. So regarding the central slip, it was mentioned that the 45-degree retrograde positioning is the best. So while doing so, is there a chance of we are taking the extensor tendon insertion more distally, so is there a chance of that extensor mechanism became tight and there is hyperextension of PIP joint and
45-degree retrograde is a mechanically favorable. That is what I wanted to say.
Okay.
That is what the author is saying.
Okay.
So that doesn't mean that I will all the cases I will do in the same way. I have shown 2 cases where one I used in retrograde and one I used perpendicular. And there are cases I did also antegrade. So it depends on case-to-case basis, I think.
Thank you.
trajectory of your the anchor. That will go a little the pull-out strength, but you are not advancing the insertion point a little bit proximal.
Is the central slip insertion just at the very near to the articular cartilage?
Maybe we can highlight that on the sawboard later.
Yeah, yes.
I think we'll move on. So one more question to Srini.
Yeah.
Like I think. Oh yeah, sorry.
Yeah, I'm Dr. Selva from Chennai. This is a question to Dr. Kiran. So, in case of ulnar collateral ligament of the thumb, most often they present as a subacute case. They always come with a POP, or a splint, and the MRI shows it's a near total avulsion or full of edema in that area. So, what will you make? What is the criteria, whether it's a clinical diagnosis or a radiological diagnosis, for you to move for an open repair in such cases?
Purely clinical diagnosis first.
But it will be very
Supported
painful
by
to
the MRI.
assess clinically. The patient will have a lot of tenderness there to
It
assess.
will be tenderness, and then additionally laxity will be there. So you correlate. So stenar lesion is one entity where obviously it is not going to heal. But if it is the only avulsion without stenar lesion, still they heal by fibrosis, and then that last bit of pinch strength or the painless movement, that still remains the deficit. Certain patients do want that 200%. So therein obviously you discuss and go for the open repair.
Single most important determinant is the laxity of the joint.
Correct.
Irrespective of your MRI finding.
Compare it to the unaffected
normal.
side.
Oh. And if you have a painful joint, put a xylocaine, assess, get the stress view, document, that's all.
Keep in mind the hyperligamentous laxity nature of the patient
So
also.
compare with the other side.
And another thing probably is, I think, the rotation of the fragment. When the fragment is rotated.
Yeah, that can be secondary. So with that,
I would like to make one comment which I didn't mention, that these fiber wires, once you take a knot and once you finish your time, we don't have to use scissor to cut them. You have to use knife. Make sure that we use knife, scalpel knife. Yeah.
So a thought for Srini. He has talked about the history. What will be the future? Maybe in the next workshop he will tell us about anchor suture, future of the anchor suture.
So in the interest of time, we'll move on and we will come back to the questions. We'll have ample time. Let's get through the talks, and then at the workshop, we'll have ample opportunity to have a lot of interaction. I'm sure you've got a lot of burning questions, so it's good. So we'll just move on to the next talk. So I think the next talk is about scapholunate ligament. Yes. So Dr. Chaitanya is now going to speak to us about scapholunate ligament using suture anchors. He's come all the way from UAE, so let's have a round of applause for him, and then he's going to tell us about scapholunate ligament repairs. Okay. Over to you.
Thank you, Dr. Ravi. At the outset, good morning, and thank you organizers and ISSH for inviting me and whole of our society to give some talks here. For this workshop, I'll be talking on repair of scapholunate ligament with suture anchors. I have no disclosures with the use of suture anchors. As you all know, this is the most commonly injured wrist ligament, and most 5% of all wrist sprains have a scapholunate tear. 30 to 40% are associated with distal radius fractures, and many are associated when you have perilunate injuries or dislocations. Quick recap of anatomy. As you all know, it is a C-shaped ligament wherein you have a dorsal part, proximal part, and a volar part. Dorsal part is the thickest one, which is the main stabilizer. The proximal one is mainly fibrous, and the volar one is what provides rotational stability. Diagnosis is, as you all know, you look at the history, clinical examination, and of course the radiology. Clinical examination in acute tears is going to be painful, so you rely mainly on radiology. What you see on radiology is there is a gap, there is a cortical ring sign if there is DC or flexion of scaphoid, and especially when you have an associated scaphoid fracture, if there is reduction in height, then you see DC. And also if there is comminution in scaphoid causing scaphoid shortening. To diagnose acute tears, you need to have an MRI if you suspect injury, dedicated wrist coils. The slices have to be less than 2 millimeters. But again, it is most important to coordinate with your radiologist to correlate your clinical findings with what you see on radiology. For classification, what I generally prefer is diagnostic scope, which in doubtful cases where you all know the 4 different classifications. And now coming to the main points, like what Dr. Ravi said, there is already some fire burning. I will add more fuel by discussing this topic because it's very vast to discuss the whole spectrum, and I would like to stick to acute injuries, which we see in various scenarios. Now, why we should repair a scapholunate injury? Because the end result is always DC, which ends up in what we call as SLAC, which is scapholunate advanced collapse. How much time it takes when you have a scapholunate injury to develop SLAC is not exactly known, but roughly, if you look at literature, it's around 3 to 5 years after having a scapholunate injury. Now, just to show this X-ray, which one is the pointer? Now, this was a patient around 45-year-old who is a biker, hobby biker. By biker, I mean he bikes on road and also on dunes, which is very common in UAE. By dunes, he is jumping with deflated tires, due to which there is constant load being applied on the wrist. He has done this multiple times, and then he presents to us with pain on the left side, wherein you see scapholunate widening, and on the right side, which is asymptomatic, he already has a SLAC, which is stage 1 with some radial styloid arthritis and gapping of the lunate. Now, coming to the timing, generally it is 4 to 6 weeks. Earlier the better, because you have lesser failure rates and you have better radiographic and patient-rated outcomes. If the injury is more than 6 weeks, then generally it needs an additional reconstructive procedure. Now, coming to adding more fuel to the fire, the technique of repair, whether you do arthroscopic, whether you do open, which part to repair, whether you repair the volar, you repair the dorsal, which approach to use, and what you use to fix the ligament. I'll stick to acute repairs, which are less than 6 weeks, with regards to approach, fixation techniques, additional procedures which you do so that you don't have DC or scapholunate widening, and how you treat associated fractures. Now, you need to have a robust ligament to repair, you need to have a reducible carpus, and you need to have no degenerative changes. Now, because my experience in diagnostic, arthroscopy is limited to diagnostic scopy. Whenever there is a need for repair, I do open repairs. When you have only scapholunate ligament injury, you can actually use the window approach, which is seen on the figure on the right, wherein you use 2 incisions in the capsule to repair the ligament. But most of the times when you have associated injuries like perilunate dislocations, the approach is already there because you hardly have any capsule which is left not open. Now, again, fixation with the availability of suture anchors, I think transosseous tunnels are only in literature. And when you do acute repairs, it is always better you add something like capsulodesis, which gives stability. Now I'll share clinical scenarios where you have isolated scapholunate injury with perlunate dislocations with distal radius and what you do when your acute repairs fail. Now if you look at this X-ray, you have a 42-year-old biker, another biker again, who fell and had an acute tear with scapholunate gap and DC. As you can see, we did a dorsal open approach. The carpus was reducible. And what is generally advised is you insert joysticks in your lunate and scaphoid, reduce the carpus, get the scapholunate together. And another important point to add here is before you do anything else, if you have reduced your scapholunate gap, I prefer to use a tall clip to keep it together while you pass the K-wires and then you get to the anchors. Again, this is very important. What to be noted here is you cannot be drilling K-wires multiple times because by that time your K-wires will have multiple tracts which you risk that the gap may increase. So make sure the scapholunate is reduced nicely. Before you insert your scapholunate wire, clamp it nicely with a small tall clip, pass the wires, and then get your anchors. So what we generally do in our practice is once we do a scapholunate repair, we also do flexion extension, fluoroscopy, dynamic fluoroscopy, and also radial and ulnar deviation to see if there is any other associated injury. And we add a dorsal capsulodesis. This is for acute tears. Generally, we keep K-wires for around 6 to 8 weeks, depending on what you see during surgery. And this is the follow-up of the patient with a maintained carpal alignment. Now, this is another case which was associated with perlunate dislocation. This patient had a polytrauma where he had other major fractures. The perlunate dislocation, in fact, it was lunate dislocation which was reduced and an X-fix was applied because the other life-threatening injuries were taken care of. Then we took him up for definitive surgery. As I was discussing before, in such injuries, you will not have an approach because everything is open. You have the whole thing in front of you, the dorsal joint. So you have reduced the scapholunate, you have pinned your scapholunate and the mid-carpal row, you have inserted your suture anchors. Again here, the point to note is generally they say scapholunate ligament is intact when you have a scaphoid fracture, but in this case, both were injured. So we reduced the carpus, we repaired the ligament and added whatever capsule was there. And then on the volar side also there was a rent in the lunotricutal ligament which was repaired. This was the follow-up X-ray, fairly maintained carpus. Then this is another case. He was a construction worker, fall from height. He had an open perlunate injury. As you can see, with a lot of contamination, some bone loss. Took him up for debridement, put an X-fix, waited for around 5 to 6 days so that you are sure there is no infection. Then we do the definitive procedure. Again, repaired the scapholunate with anchors, pinned the scapholunate, the lunotricutal, and also because the radial styloid was injured, we repaired the radius scaphocapitate with an anchor. This is after K-wire removal, fairly maintained alignment, and good healing of the radius scaphocapitate. Now, this is a scenario which is very dicey because I'm sure some of you have had this experience. This is an acute repair. Everything looked good on fluoroscopy. We reduced the carpus nicely. We did a dorsal capsulodesis. At 4 weeks of follow-up, this is what you see on the X-ray. Now, if you remember the biker who had bilateral wrist, one side scapholunate ligament injury with a gap and other side slack, when you see something like this happening in your post-op patient at 1 month, you would definitely want to correct this. So here we did a 360 reconstruction with a palmaris longus reinforced graft. Reduce the carpus. Of course, it's not the best of reduction, but We did this, put an internal brace, and he's doing fairly okay. As we have already discussed the complications with suture anchors, I'll skip this. To summarize, for scapholunate repair with suture anchors, there is heterogeneous literature which again doesn't support the use of one approach or one way to treat it. Window approach is theoretically better. The most important is use K-wires as joysticks to reduce. Add dorsal capsulodesis in acute tears so that your outcomes are better in terms of radiological and clinical parameters. Arthroscopy, if your expertise allows that, it avoids large exposure, but it has a learning curve. Thank you.
Thank you very much, Dr. Chaitanya. That was a very nice talk. So we'll take questions at the end. Yeah. So in the wrist module, moving forward, we have Dr. Shailesh Gupta from Indore. He is going to be speaking to us about his experience with use of suture anchors in radiocarpal dislocations.
Since last 20 years, I am trying to make my problem simple. And definitely, it is getting simple and simple now. If I look at the hand surgery, what I used to do 20 years back is getting much simpler nowadays. Similarly, the Albert Einstein says everything should be made as simple as possible, but not the simpler. So I will have 10 tips for managing the radiocarpal fracture dislocation and radiocarpal dislocation. First and foremost thing is not to miss it. I have missed many in first 10 years of my practice. Though reasonably they were having a good range of motion because most of the motion were happening at the mid-carpal joint. Remember, the mid-carpal joint gives a 60% range of the motion. Despite deformity, patients were not so unhappy. I am saying they were not so unhappy. They were unhappy, but they were not so unhappy. So first thing is not to miss it. How not to miss it? You should know how the radiology looks at. If you intersect vertically the lunate, the line pass to the DRUJ. But when you see a radiocarpal dislocation, you make the similar line. Look at where is the lunate. Lunate is far away. It has migrated radially. What else has been migrated with the lunate? The whole radius, carpus has migrated along with the radial styloid. Look at the ulnar styloid, which is also migrated. So first thing is not to miss it. Assess your radiology properly. Similarly, assess the lateral view. Look at the line, vertical lines, by where the lunate is intersecting anterior-posterior plane and where it is going on the radius. And look at this in a radiocarpal fracture dislocation, where it is. It's far away. It is not following the radius. Look at the capsular avulsion. Don't think, okay, we need a rim plate, we need a suture, we need that. Just for the sake of classification, Ravi was very particular. It has to be in the case-based discussion. So just for the sake of classification, it's a two type. One is pure ligamentous, which is type 1, and one is pure, there is a fracture dislocation of the radiocarpal joint. So what next? Assessing the radiology, not to miss it. Be liberal in ordering the CT scan for associated injury. Remember, it's a very high velocity injury. You may have associated capitate fracture. You may have associated scaphoid fracture. So not to forget to order the CT scan. It has to be not a mandatory rule, but it has to be in your protocol if possible. Fourth thing, understanding the ligamentous anatomy of the volar aspect of the wrist. This picture is from the Growing Hand, written by my professor, Dr. Amit Gupta from Louisville. Look at where this is the radial styloid, from where the major long radiolunate and radioscaphocapitate ligament is going on. If the radial styloid is fractured, along with short radial ligament has been avulsed, there is a high chance that everything will migrate on the dorsal radial side. And look at the dorsal radiocarpal ligament. Actually, in the all radiocarpal fracture dislocation, there is a radioscaphocapitate ligament, long radiolunate ligament, short radiolunate ligament, and dorsal radiocapitate ligament avulsion. These are the major stabilizers. If they are avulsed, the carpus is going to move in one direction to another direction. So let's look at the practical implication. So if I fix the radial styloid, I don't need a fragment specific fixation for the radial styloid. If I fix with the radial styloid, I am taking care of this radial ligament complex on the volar side. Then if I use the anchor suture, that's the easiest. That's if I use the anchor suture, I am handling the short radiolunate ligament. And if I use the dorsal side opening anchor suture, then I am taking care of the dorsal radiocarpal ligament complex. That's a practical application, just opening on the small radial side, opening on the dorsal side. And once you have done that, you can see the alignment. It's pure, consider it's a more of a carpus ligamentous injury rather than the fracture. Seventh principle, do not think of volar locking plate. As Chaitanya has taken a talk in American Hand Society, here are some fracture where you should not think of the volar locking plate. Again, looked so complex that the radial styloid needs a sort of reconstruction, bone graft, but look at that. Once the carpus ligamentous anatomy is stabilized, you don't need any other mode of fixation. I usually prefer a screw or a combination of K-wire or screw, or depending on the feasibility, I can just go with the K-wire. It's again, look at the anchor, one is on the anterior side, one in the posterior side, which is causing the capsule to in its footprint, which hold the carpus bone. Look for associated injury. Look at that DRUJ is somewhat unstable in this case. Along with that, there is a proximally elbow is also unstable. So because these are high velocity injury, look for the associated injury and manage accordingly. Keep the additional implant to be ready on the table. Here when I applied everything, here I never realized it can be a more problem, but look at the way when the ligament was not held by the forceps, the carpus was still subluxating, but the moment I hold the ligament with the forceps, the carpus came into its position. So here the anchor suture was required, but still the joint was unstable, so I added an external fixator for the period till the soft tissue healing happens. In addition to that, keep a wrist spanning plate in your ornamentarium, so that if required, you can put a temporary internal fixation for the wrist joint. And last, prognosticate the injury. Be liberal in carpal tunnel release. Tell patient that you may end up in some restriction of the movement. And if there is a carpal subluxation, ulnar carpal translocation, if the carpal translocation at the wrist happen, tell him it's a non-salvageable condition. You may require a wrist fusion in future. Thank you very much. So everything should be made simple as possible. Anchor has made my life much simpler now. Thank you very much.
Thank you, Dr. Sailesh, for an excellent talk. We'll take questions at the end, like I said. Now moving on, from the wrist, we'll go more proximally and we'll go to the elbow joint. And it's my pleasure to invite Dr. Rohan Habu from Mumbai. He's going to be speaking to us about use of suture anchors in triceps and biceps avulsions of the elbow.
Bit short and sweet. No conflicts. Now first about biceps. We'll focus only on the distal biceps tendon avulsion. Always remember, it's not a single spot insertion, it's a fairly wide insertion. So we always try to create a wider repair than just a shorter repair. And that's why maybe just a single anchor may not be sufficient to get that surface area of a repair. So we'll see what all we can do. in literature, these were the different techniques defined. This is a single anchor technique. This is a tenodesis or interference screw. This is the docking technique where you can put the tendon back into the radius so that you have a more surface area for healing. And obviously the pull-outs. There's no one good technique or bad technique. We have tried to do everything. And what I've realized is the more the surface area that you have the tendon healing onto the bone, the better is the healing and the strength eventually. This especially when you try and treat a muscular guy who really wants to go back and lifting say 20, 30 kilos. So if you use a single anchor, this is probably the surface area that you'll get. But if you use a docking technique and an anchor, or an anchor and an anchor, and pull this tendon down over this entire area, probably about 1 to 1.5 centimeter of the radial tuberosity, you will have a good healing of the biceps tendon. Quickly, it's an anterior Z incision. Everybody knows about it. The moment you open the skin, there is a good amount of hematoma there. You will be able to identify the biceps tendon. One trick is don't try to rip it out from where it is. You try and, the biceps tendon, the nature itself will form a tract and allow you to navigate down into the area of its insertion, that's the radial tuberosity. So typically when we see a biceps tendon like this, we don't rip it out. We try and put the finger down, all the way down onto the radial tuberosity because there is a nice tunnel, and then try and dissect over your finger. Eventually, you'll reach down onto the radial tuberosity. Now, it's not just a point, it's a fairly wide tuberosity. We try to use the distal half of the radial tuberosity when you do the fixation of the biceps tendon. We use two places of fixation, okay? The first one is right here. This is right at the distalmost part of the radial tuberosity. Your hand is in complete supination. I like to prefer a docking technique and an anchor, but you can also put an anchor here and another anchor about a centimeter proximal. You can decorticate this area so that you have a nice bleeding healthy bone, okay? The anchors that you can use are a little bigger than what our previous speakers have said. These are about 2.4 millimeter anchors, which could be biodegradable or non-absorbable. I have not used a titanium anchor in radial tuberosity. The radius is quite narrow, so anything more than 2.4 might compromise the medial and the lateral wall. The other type of anchors that you can use would be the suture anchors that some of the speakers have described. So what I typically do, I either make a tunnel which is the width of the stump of the biceps. You drill it halfway down into the radius. You can actually see, don't go all the way across onto the other side. And you pull it down either with a button or make two drill holes across the dorsal cortex. Before tying this down, you put an anchor here. I usually prefer a suture anchor because it's quite narrow and it's quite easy to put. And leave the 4 threads, so the 2 threads out, sorry. Then you tie down the anchor or dock the tendon down here and then tie this down. So you have a good surface area in this region. So this is the final tension. You can see the tendon all the way down going here. I'm sorry the pictures were not clear because it's in depth. But despite the full extension, this is not retracted back and this is not lax. So you really get a rigid, robust fixation that allows you to move the patient a bit early. These are the C-arm pictures. The suture anchor is actually quite small, so I don't think so it's visible here. And that's the post-op picture. I think that's the little shadow that you can see. And that's the patient at 2 months. We just immobilize them in a sling. We start active-passive range of movement, obviously no weightlifting. And this is about 2-month mark where you can just see the little curve of the biceps. Now the triceps is a bit different. It's not a cord-like structure like the biceps tendon. It's a fairly flat structure and it has an insertion all over the olecranon tip. So it's like a fairly flat. So it's very difficult to dock the triceps tendon. So it's always better to use anchors for the triceps. The good part about it is, sorry, the bad part about that is you have a flat structure against a flat object. So it's very easy that if something becomes loose, there might be mobility at the repair site. But the good part about triceps is that there are medial and lateral retinaculi, which actually when you repair, will reduce the tension on your anchor repair. And we'll talk about it briefly. The different ways to repair a triceps tendon is obviously the pull-out stitches that has been time and tested. You can use a single anchor, and our preferred technique is using 2 anchors. Now again, these are 2.4 millimeter anchors, or you can use suture anchors. In triceps, I prefer to use the bioabsorbable anchors and not the suture anchors, because we use a double loaded or triple loaded. I have not seen a suture anchor which is double loaded. So that is the one reason why I don't like to use suture anchors here. This is an arm across the supine position with arm across the chest, a standard midline incision curving around the olecranon. Identify the ulnar nerve and keep it aside. So these are the 2 anchors. Now, where on the lateral view you will put? You need a good surface area, so you definitely cannot put them here. You need a good bone, but if you try and put it somewhere here, there's a lot of distance that the triceps has to cover. You might put them in tension. So if you draw a line from the coronoid and cut it somewhere here, so these are the 2 places where you can use. You have good depth of bone and you're not extending or elongating the triceps. So you can see those 2 anchors here. I think this was a triple loaded anchor if I'm not wrong. And then we pass it through with multiple or with a simple stitches, because you have now 6 threads. And you repair it back. Now these are these additional retinaculi repairs that I was talking about. These actually reduce the tension on your actual anchor repairs. These guys do quite well, but in this case, because it's a surface to surface repair, I would immobilize them for at least a month and then start the range of movement. So take home message for anchors in the elbow area is you need to use some bigger anchors, about 2.4 millimeters, or use suture anchors. I feel just the anchors are not enough. So for the biceps, try and use an additional reinforcement. For me, it is a docking technique. And for the triceps, is definitely repairing the retinaculum. Thank you so much.
So, thank you. Very nice demonstration. May I call Dr. Sunil from Hyderabad for his talk on elbow instability. Correct?
Thank you, sir. Thank you, ISKCON, for inviting. So my talk is on role of suture anchors in elbow instability, how to get good outcomes out of this. As we all know, we are usually afraid of elbow injuries because it usually results in 3 common complications. One is persistent instability because of missed injuries, post-traumatic arthritis because of missed or ill-treated injuries, or stiffness and pain. And all of these are detrimental to the patient, and we would like to optimize the results in terms of these injuries. So what are the points to consider when you're treating these is to identify the injury pattern, whether it's a fracture, isolated, whether it's a fracture dislocation. Assessment of stability is a commonly missed thing after a reduction of an elbow dislocation. They inevitably go into a plaster, and at the end of 3 weeks, you notice that there is amount of subluxation. Identify the osseous component of the injury and address the ligamentous part as well, and rehabilitation at the end. So if you're looking at the primary stabilizers, the elbow joint as such is a very congruent joint at the ulnar-humeral joint, which is a primary stabilizer. The other primary stabilizers are the lateral complex, which is the LUCL, or the lateral ulnar collateral, the RCL, and the annular ligament. And on the medial side, it's the anterior and posterior bundles of MCL. Anterior bundle is the primary stabilizer and usually escapes injuries in most of these injuries. It has 2 components, again the anterior band and the posterior band of the anterior MCL. So that's about the primary stabilizers. We also have the secondary stabilizers like the radiohumeral joint, the capsule, and the flexor and extensor origins. All of these complex make it a stable joint as such. So there's an interesting Franzi's thumb rule, which tells you that your thumb should be immobilized or your ligament should be tightened in the position where the ligament is intact. So if it's a LCL injury, your thumb should be facing the MCL, that's a pronation. And if it's a MCL injury, your thumb should be facing the LCL, that's a supination. So that is a position which will guide us in a relaxed and a appropriate repair. A case example of a male patient, this was a terrible triad injury, unstable after a reduction, shows a comminuted radial head, a coronoid, and a typical approach would be a coccus. Considering the multifragmentary fracture, it was destined for a radial head replacement. And common thing what we see here on the lateral side is your LCL and the common extensor origin is Avelsdorf. You find that typical bare area around the lateral aspect. So if you look at the lateral structures, there is a lot of things going on there. You have your extensor origin muscles, and your LCL is right deep inside that extensor origin and usually in confluence with these extensor origin muscles. And if you typically see where this LCL starts, it's at the center point of the capitulum, which is the isometric point, and inserts onto the supinator crust on the ulna. I'm speaking about the LUCL. So that's the origin and that's the insertion of the typical LCL. So whenever you're thinking of repairing this LCL, you have to find out this isometric point, which is the center of that circle of the arc of capitulum. That's the bullseye where you have to deploy your anchor. And usually I go for 3 mm size metal anchors, which come with preloaded sutures with needles, which make my job easier rather than going for all suture angles where you have to put a needle into. And for an LCL, the tensioning is a concentrically reduced elbow with 90 degrees of elbow flexion with full forearm pronation, like the rule which I have said before. And always repair the extensor layer on top of your LCL. And finally, you have to assess the MCL. We all know that the Horry cycle, which starts on the medial lateral side, ends at the medial side. You may or may not have a MCL injury, but that has to be assessed after your LCL repair by asymmetrical gapping. It is not that easy to check that valgus stress because your humerus starts rotating and it's difficult to assess it. So always pronate the forearm and check for the laxity on the medial side. So that's how a typical avulsed LCL would look like, and you look for that center point of the capitulum, and that's the avulsed ligament lying deep inside the extensor muscles. So you grasp them, deploy the anchor and tighten it up. And it's common that sometimes the anchor just pull out from the lateral side. Compared to the medial side, you have dense bone, but the lateral side, the bone is not that dense and the anchors may actually pull out. So you can secure them quite deep inside in the region of the condyles or into the lateral column. And the anchor should be typically looking like that the bullseye lesion in the center of the capitulum. And what happens if you don't take care of this, or in isolated lateral ligament injuries, if you're not repaired them, what you end up is called as a posterolateral rotatory instability. So with every motion of supination in flexion extension, the radial head pops out and subluxes posteriorly. That's called the PLRI. And again, if it is detected, usually it ends up with a chronic situation and you have to go for a ligament reconstruction of the LUCL with the free tendon graft. Coming to the medial sided injuries, you have a discrete ligament on the medial side, unlike the lateral side, which is blended with your extensor origin. You have a MCL, anterior MCL, which is the most important part. And contrary to what we think, it's not the medial epicondyle, but way below the medial epicondyle, right in the cubital tunnel, it's your MCL origin. And that's way below what is expected. And your insertion on the ulna is on two parts. The anterior MCL inserts on the sublime tubercle, while the posterior MCL inserts on the medial part of the olecranon. So how do you approach an MCL injury? You go for either a medial if it's isolated, or in complex injuries, posterior approach. Always isolate and protect the ulnar nerve. And your anchor can be transverse or obliquely oriented depending on the comfort and the ease. Another case example of a complex elbow injury where you have a large coronoid fragment, and what you see here is a low-lying avulsion of a common flexor origin. So we assume that it's a UCL, but it's not the UCL, it's a flexor origin avulsion. And with that kind of a picture, when you open, everything is ripped off internally. You find that the ulnar nerve is nicely dissected out because of the injury. Your UCL is Avelsdorf from the insertion on the ulna, and your common flexor origin is Avelsdorf from the humerus. You fix your coronoid and address the ligaments appropriately. You put your anchor on the sublime tubercle for the anterior MCL and repair it, another anchor to repair the flexor origin. Coming to coronoid fractures, we all know the Regan-Murray classification, which determines the height, but O'Driscoll is more relevant clinically in terms of assessing the stability and its relevance in post-reduction stability of the elbow. So how do you fix a coronoid? Like previously, if it's a large fragment, you can go for internal fixation with plates, screws, whatever. But if it is a comminuted avulsion kind of a picture, you can get away with suture anchor or pull-out suture. Given an option, I would always prefer a pull-out suture. But anchors, if my position of the patient doesn't allow me to go for a pull-out, I go for an anchor. What approach we do for coronoid? There are many, many various approaches. The first one is a medial over-the-top approach, which doesn't give a good exposure of the base of the coronoid. FCU splitting is always what I prefer. I go through the ulnar floor, separate the two heads of FCL, and you are right on the coronoid base. Taylor sham is where you elevate the entire flexor pronator mass from the ulna, and the flexor pronator split is an extensile approach. So you can choose the approach depending on the fracture configuration. Another case example of a closed elbow dislocation found to be very unstable after reduction. X-ray hardly shows anything except for some bone spike on the volar side. But when you take the CT, it reveals some pictures. You have an avulsion on the medial side, you have an avulsion on the lateral side, you have an avulsion on the coronoid side, and you find that the capitulum, the radial head is gone below the capitulum. So it all is together imply a clinically unstable picture. And you have to address them individually. Go from the medial side, you find that the UCL is ruptured from the ulna. You have anchors deployed in the coronoid as well as in the ulnar UCL footprint, and the lateral approach for the LCR. And that's how a stably reduced soft tissue, pure soft tissue repair of a complex elbow dislocation looks like. And a final case of another young fellow with a terrible triad injury, unstable after close reduction. You find that the coronoid is comminuted and a fleck of bone on the anterior and the anteromedial rim. So that shows the coronoid. It's not that easy to deploy an anchor in the coronoid base from the medial approach, because the direction of the anchor usually tends to go off laterally. That's a humeral sided avulsion, that's a lateral sided avulsion, and that's the typical picture of how a medial lateral repair along with the coronoid repair is done for avulsion fractures. So, and what do you do during a combined repair? When you're doing which one do you do first, how do you tension them? It's a personal choice, but because the MCL is short and stout, I repair it first in supination, then I go for the LCL in pronation. And finally, coming to rehabilitation, all these patients end up in a splint for about 2 weeks. And the most important thing is we tend to immobilize them in a standing or a sitting position. Actually, the gravity stresses the repair and they tend to sublux. So supine position with overhead flexion extension is the one which actually helps you in maintaining the reduction throughout. And forearm rotations are started. Avoid shoulder abduction during any of the rehab period for 2 weeks, because that stresses your lateral repair and puts stresses on the anteromedial tip also. And strengthening is recommended usually 6 to 8 weeks after your repair. Thank you.
Thank you very much. So usually the great men always come last. So that's why I'm calling Abhijit Vahegavkar for the last presentation. And he will be talking about the most discussed, most sought after topic of TFCC repair. Everything in the ulnar side, everybody considered to be a TFCC, TFCC, TFCC. So, but the time will remain same, 10 minutes. Huh?
And actually, I regretted making my talk so brief, so please bear with me. Good morning, everyone, and I'm very grateful to my dear friend Ravi, as well as Dr. Shailesh Gupta, as well as the organizing committee of the ISSHCon 2024 for the opportunity to speak to you. My charge is to talk about the knotless repair technique for TFCC foveal avulsions, and I'm sure a lot of you must be doing it already. So this is just going to be a brief review of what we do. But before I begin, I would like to acknowledge and express my gratitude to this one man, Professor Christoph Mathula, who taught me like a father would teach his child, holding my hand and telling me, teaching me everything that there is about the wrist joint. And especially so because I'm not sure if very many of you know, he's battling a cancer as we speak, and he's coming out strong. So request you all to please pray for him. This is where I work. This is a place called Sahyadri Hospital and Sanjeti Institute for Orthopedics and Rehab in Pune. Now the indications for a repair of the TFCC would usually be an acute or a subacute unstable DRUJ, usually resulting from a fall onto an outstretched hand and when the DRG is unstable. So we talk about repairs only when there is repairable tissue, there is a potential for healing, and then you may want to do this either arthroscopic or open using suture anchors or whatever technique that you fancy. That's the kind of instability that you would encounter in a majority of these patients. Unfortunately, we still do not have a guide to assess the grade of instability, but that's pretty much a multi-directional instability, if you will. The traditional method of dealing with these instabilities is the use of a suture anchor, pretty much like this, but then unfortunately this leaves a suture knot within the joint. And I'm sure that a lot of you would concede that pushing that knot down and pushing the TFCC back onto its footprint can be quite tedious in this very tight space that you encounter here. But this is how we were doing it before the advent of newer techniques. And I'm sure that a lot of you must be also familiar with this technique of Nakamura, which was the foundation for a knotless repair technique wherein we make these transosseous holes using the jig that he described. It's basically an aiming or a pointing device, pretty much like you use for the ACL, and you make two parallel holes into the ulna going on to the articular surface, weave your sutures in a horizontal mattress and you pull it down and you tie it down to the metaphyseal region or the diaphyseal region of the ulna, so it does not leave a knot within the joint. So there are certain advantages of the knotless technique. There is no intra-articular knot, so there is no irritation between the carpal bones and the knot. It's a more robust repair because you're pulling down the TFCC rather than pushing it down, which can be quite a daunting task in that very tight space. And of course, then you perhaps theoretically have a larger footprint, pretty much like we talked about the biceps for repairing the TFCC down to the ulna. More recently, we have had these push locks that have facilitated the reparative technique of TFCC, which gives a very robust and a very secure fixation of the sutures to the bone. And this is the video that kind of highlights the technique. I'm sorry I don't have the intra-articular video, the recording on the system, but this will kind of show you how we get our sutures into the volar radio-ulnar ligament, then onto the dorsal radio-ulnar ligament, and then you make a horizontal mattress suture. We retrieve all of these through the 6U portal itself so that we have a nice transverse horizontal mattress suture. And then you can also make a modified Mason Allen if required if the TFCC is not very healthy. Once you have done that, you retrieve your sutures from the 6U portal and then you make a small incision more proximally in line with the 6U portal. And then you have your fiber wire sutures retrieved out subcutaneously, pretty much like so, and that kind of shows how we are able to pull down the fiber wire and then get the TFCC down. At this juncture, we use a periosteal elevator to expose the bone through a small incision, and then we kind of make a small drill hole to match the size of the depth and the diameter of the push lock, which is 8 millimeter in depth and 2.5 millimeter in diameter. We begin with a smaller drill or a K-wire, 1.5 to begin with, and then we enlarge that hole to a 2.5 millimeter diameter. So here I'm using a small periosteal elevator to elevate or to clear the periosteum and the soft tissue. And then after we have done this, of course, you need to pay attention to the dorsal cutaneous branches of the ulnar nerve, put them out of harm's way, and then we have the bone ready for the drilling. So unfortunately, we don't have the stopper nor the drill bit that's available with the suture anchor, so we make do with this kind of a indigenous technique or jugaad. We mark 8 millimeters on a 1.5 and a 2.5 millimeter K wire sequentially, and then you make a small drill hole into the bone under vision, so that you have your drill hole ready to receive your push lock anchor. At this juncture, then we bring in our mini push lock to get the fiber wire pretty much like so. You can see the push lock out there. And then one of your assistants or colleagues would hold down the, and understand that this is all without any traction. So the hand is just held vertically to just facilitate the working. There is no traction onto the hand. And once you have done that, we just tap the mini push lock in, and we secure the repair in a very robust manner. And that's pretty much the end of it. We seat the anchor very well. And then, as Parag had admonished, you do not cut these sutures, but you use a blade to cut it off. Once you have the push lock off, that's the excess fiber wire that we now section like so. And then, of course, you would want to assess your stability and ensure that it's stable in all three rotations: mid-prone, pronation, and supination. So that kind of gives very nice stability in most of the cases wherein the ligament is repairable, has a good healing potential, and is an acute or a subacute injury. So at this juncture, we kind of immobilize the forearm in supination with the wrist in slight extension and ulnar deviation for about 4 to 6 weeks, after which the slab comes off, and then we rehabilitate the patient. So with that, I would like to thank you all. This is the incredible team I work with, and I would like to acknowledge them who make all these surgeries look easy. Thank you so much.
Thank you, Abhijit, for finishing complex topic well within time. So what you all were hiding the facts. Ravi is coming as a devil advocate. He is telling the audience that what everything has been hidden by the various speakers. So please don't mind all the speakers. It's not personal. Dr. Ravi Bhardwaj for the devil's advocate.
Good morning. So, Shailesh asked me to, give you the other side. We have been hearing the entire morning speakers waxing eloquent about the benefits and the ease and the multiple myriad applications of suture anchors. I'm here to tell you that, not everything goes to plan, and maybe take you through some of my own complications. So, bear with me. So, I'm here to play the devil's advocate, and with all apologies to William Shakespeare, here's a quote which I often make: "The evil that surgeons do live after them, the good is often buried with their bones." So with that, let's talk a little bit about complications of suture anchors. What can go wrong? Because if we didn't have this talk, you will go away with the wrong message that everything is easy, hunky-dory, easy peasy, lemon squeeze. It doesn't work out that way always. So loosening sometimes can happen, and especially in osteoporotic bone, if you're not careful, wrong technique, wrong selection of anchors, poor bone quality. So, and the tensile forces at play also. Sometimes you could be having an anchor pulling on a very strong tendon like in the FDP. So you have to be careful. Migration of the anchor has been reported. You could get chondrolysis, especially if the part of the anchor is protruding into the joint, or even as a result of the, some bioabsorbable anchors. Chondrolysis has also been reported, not just with metal anchors. Hypersensitivity. There have been, sporadic case reports in literature, where, patients have been reported to have metallurgy, and especially in the setting of metal anchor, nickel sensitivity. Persistent discharge, we often see this mostly with bioabsorbable anchors, especially in a superficial location. Like if you're using it, in the subcutaneous location of the anchor, you could end up with a very bothersome, persistent sterile discharge for weeks or months, and synovitis in the joint itself. So these are some of the complications. So basically, if you look at the complications and you look at them and you put them into headings, so they can be related to improper size. They could be related to the implant type. So specific implant types have specific complications. If you are a shoddy surgeon like me, improper technique, maybe you could end up with some of the complications I'm about to show you. And sometimes, you feel all is well and you're so happy with the results of your surgery and you think, okay, I'll get them mobilizing from day one, and you're over enthusiastic with your rehab. Even then, you could end up with some pitfalls, and then some of the complications could be related to the rehab process itself. So, I ask you this question, no innuendo, does size matter? Of course it does. Size does matter, and you have to choose the size of your anchor, so it's a balancing act and the proportion has to be right. It can't be like in what you see in the slide. So good things don't always come in small packages, so you have to choose your anchor size correctly. This is when I had a very robust, young, fit bodybuilder, and it was a wrong choice of implant. If you look very carefully, it's quite a large bony fragment, probably not an ideal case for an anchor. I think someone was asking in the morning, what do you do when you have a situation when there's a large bony avulsion? This is something probably where the implant should have been different. We could have used pins, K-wires, screws, whatever, but should not have been a suture anchor, and you can see what a large size of bone. So obviously, this is almost like a day one failure, you can say. So, and on top of that, even if you had to use an anchor, that's probably a very small anchor. A slightly bigger anchor would have been used. So, size and technique both wrong here. Bigger is not always better. So, one more instance where I had a momentary lapse of reason, where I specifically asked the implant person to provide the anchor, and the anchor, without showing me, just opened it on the table. And he just said, I remember those words, this was about a decade ago, 2014-15. He said, sir, khol diya to use hi kar lo na. And I don't know what I was thinking, I wasn't in my right mind, and I did that. It's a 2.4 anchor wedged in a distal phalanx, and the results are not very great to see. So, how we had to sort of bail out, only I know. Spent about an hour trying to reconstruct the joint with K-wires, pull-out sutures. Our faithful pull-out sutures came to the rescue. Somehow we salvaged the situation and managed to bail out. But again, size does matter. Mallet finger. Again, sometimes you get seduced by technology, and someone came and said, sir, this is this new bioabsorbable anchor, you must try. It's so small, it has such a small footprint, in X-ray mein dikhta bhi nahi, aapko ye try karna chahiye. So I said, the next available case, it was a mallet finger, went ahead, did it. And this patient kept coming to my OPD every week for 3 months, and I would feel like running away when I used to see the patient. I used to tell my secretary every day, I had this phobia. I would ask him, is this gentleman coming to see me today? And he said, हाँ sir, वो wait कर रहा है. Then I would find an excuse not to see him and try and send my registrar out to see him, because I cultured it at least 4 times. Every time there was a sterile discharge, but he would come and say, sir, finger to theek hai, lekin ये पानी पानी कुछ निकल रहा है. And this is what happened in the X-rays. Eventually, it settled down, but it gave me a few sleepless weeks and months, you might say. So this is something to be aware with bioabsorbable anchor, especially in a superficial location. Never use them for a mallet finger. I'm speaking from my own experience. Once bitten, twice shy. Okay. I'm glad Abhijit did his talk, because this is with a push lock anchor. Abhijit makes it look so easy, and I thought, okay, I could be as good as Abhijit, and I, whacked away, and I came out, and I thought, okay, all is fine. So he was fine as long as the patient was in the plaster, but when I took the cast off and started mobilizing, he said, yeah, the wrist feels pain, that it's a different kind of pain, but it's more sort of, proximal, where, we had made the proximal incision to hammer the push lock anchor. It was no longer at the fovea or where the TFCC tear was, and this was after 8 weeks. So, I didn't know what was wrong, then got X-rays, couldn't say anything. We decided to go in and explore, And this is what was happening. We were having to play peekaboo with a peak anchor. This was a TFCC repair with a mini push lock anchor. Pain developed within a few days of taking the patient out of the cast. On an exploration, we found the implant to be a little bit more proud and prominent. So we were careless. We didn't hammer it all the way in. See, you don't have the custom-made jig and you try to improvise with your marking, use a K-wire and you mark it. And my assistant thought he had drilled it enough. It was supposed to be 8 millimeter. It wasn't seated deep enough. It was protruding out and it was irritating the tendons, and this is what we had. What did we do? We just trimmed it and the pain settled and the patient went on to heal nicely. No problems after all. So, you know, things may be simple, but then technique has to be right and you have to follow through the proper technique. If you, there's no room for complacency. You know, if you get careless, it comes back to bite you. Jersey finger. I always get this when I use a suture anchor, you know, this feeling, you know, I don't know how many of you get it, but when I try, you know, it's been recommended, I do it myself, but every time I think this is the anchor, this is the FDP tendon, and this is what is going on in my mind. And sometimes this happens. Okay, so this was a Jersey finger which we got an X-ray. It was like a, you know, a double avulsion here and here. So we just got an MRI just to be sure about the extent of the, you know, the proximal retraction at the middle phalanx. Went ahead, opened it, fixed it with a suture anchor, and then, you know, this is what it looked like. This is just one of the needles coming on the X-ray. Seemed to be nice with the cascade, rescord, everything all and then. But on rehab, you know, I don't know whether it pulled out or stretched out. We never got back the flexion, the good flexion which Parag showed in his X-ray. So maybe it pulled out, maybe it was not a very secure fixation, maybe we should have. So from then onwards, even if I use a suture anchor, I often end up as a, you know, a double protection, I use a pull-out as well. That's a personal preference. I'm not saying maybe it's me, maybe it's my poor technique, but yeah, it's one complication you all need to be aware about. So I went ahead and thought, is it me only who is a bad surgeon and is getting all these problems with anchors, or is there, you know, other people who have had the same fate? So I took some sort of solace in the fact that I was not alone, and, you know, if you look into literature and the other complications similar to what I have seen. So this is from the Journal of Hand Surgery 2011, foreign body reaction osteolysis by, you know, this is a PLA anchor. A 50-year-old lady had a dorsal scapholunate avulsion repair with 2 anchors, and then she went on to develop pain in the wrist, synovitis, chondral erosion, osteolysis in the MRI, and they found when on exploration 2 broken fragments of the anchor material floating in the midcarpal joint. So that needed to be removed at open surgery, and after that her symptoms settled. So this was another paper from Hand in 2016, Zeidenberg et al. Similar kind of foreign body reaction osteolysis. This was again dorsal lunate dislocation repaired with anchors. This was 6 months down the line, intraosseous foreign body reaction, and they took a synovial biopsy, and this was the histology which showed a foreign body reaction. And then subsequently a year down the line, there was 21 months down the line, I think, there was a huge amount of osteolysis and the massive osteolysis of the proximal carpal row, and ultimately, 12 months later, they went ahead and did a salvage surgery. They had to remove the entire proximal carpal row, so PRC had to be done. So a humbling thought, you know, not always everything's go according to plan. If you get a complication, you have to be alert to the possibility of something and intervene early rather than bury your head like an ostrich and be in denial mode, oh, nothing can go wrong, I've done my surgery properly. It's also necessary for the surgeon to be aware of these possibilities so that he can pick them up early. This is another study by Jeffrey Chen from Journal of Hand Surgery. It's very recent, this last year, August 2023. They studied 26 patients, and then 7 out of those 26 patients had a 27% osteolysis increase in the size of the tunnel of more than 30%, you know, from what they did. So it's a third, and if it's a small bone like a lunate, you can imagine, you know, even 30% increase is massive. And in all their cases, so in all the 26 patients, there was an average size of about 19 point, almost 20% increase in the tunnel size. And this is with a peak anchor. So sobering thought, careful, especially in the smaller bones of the wrist. So I leave you with the sobering thought. Do any of you know what this is or who this is? This is from Greek mythology. So if you've heard of the Odyssey by Homer, who is a very famous Greek poet, and in the book by him on the Odyssey, he alludes to this legend of these sirens. These sirens were nymphs who were bewitchingly beautiful, and they sang in a very ethereally tantalizing voice, and they would be seated on the rocks on the Aegean Ocean, and the passing sailors would listen to the music, and then they would get so distracted that the ships would crash on the rocks, and this led to disaster. So just like, these sirens used to seduce the surgeons of the day, as is mentioned in Homer's book, The Odyssey, tech companies come to us with very, tantalizing sounding names as if to tempt us. So you hear of names such as Quick Fix, and you think, okay, it's really a quick fix. And then Iconics, you think I'm going to be an icon if I use it. Or maybe a Juggernaut, that makes you feel like Rambo in First Blood. So you feel very invincible, I've got all these tools, and I'm going to be a great surgeon, I'm going to do. The sobering thought at the end of the day is, all these might be very good technology, but at the end of the day, they are just a useful way of reattaching the ligaments and tendons to bone. There are various types. Of course, there is a versatile application, but the surgeon should be aware of the risks. They are not foolproof in any way. And last but not the least, there has to be a meticulous attention to the technique, because they can be very unforgiving and very difficult to revise. So, end of the day, arrows comes in many ways, and as the saying goes, you have a variety of arrows at your disposal, but end of the day, it's the person shooting the arrows who's important. So if you choose your arrows properly, you'll get a bullseye, because it's never about the arrows, it's the archer who matters the most. Thank you very much.
Thank you, Ravi. So straightforward, we are just at time now, not running exactly out of time, because we will go with the company video how to fix the anchor suture, and then we'll come gather here for the sawbone workshop. I request all the gentlemen who have registered earlier, though you are all registered for the conference, I am not denying that, but those who have registered for this workshop, allow them, those who have registered, allow them to come forward for the actual sawbone workshop. And those who have not registered for the workshop and still they are into the hall, they can watch the things. There is hardly anything to do in the workshop, but still, it's a promise from the organizer. Those who have registered will be allowed for the sawbone workshop.
So basically, this workshop academic partners with Biotech, so they have a product video by one of their surgeons. So we'll have a quick look at the video. It's a corkscrew type of anchor. So anchors come in various designs. So we have limited amount of about 20-25 anchors, I think, and some sawbone models. So each of you can take a look after the video is played at the anchor, and then familiarize yourself with the product. And then we have a few sawbone models. And like Shailesh said, if those of you have specifically registered for the workshop, probably they come and do it on the sawbone if they want. Others can obviously join in. Everybody is welcome to join. But we would request that the people who are registered initially for the workshop be given the opportunity to use in the interest of fairness. So we'll play the video and then we'll go on to the sawbone workshop. And in the meantime, feel free to reach out to all our faculty. It's not that, just because we are faculty, we have all the answers. If you have problems, share them with us. We'll share our problems with you. We learn from each other. So it's a two-way process. Yeah, okay. Yes. Oh, thank you, sir. Thank you very much. So I think the video has no sound. I'm seeing the video for the first time, but I think from what I'm seeing, it's an open TFCC repair where there's been a foveal avulsion and a corkscrew anchor has been placed at the fovea. And now the fiber wire sutures are being passed to reattach the foveal deep part of the
TFCC. Abhijit, please correct me if I'm wrong. I'm scared to speak when Abhijit is in the room, you know, about wrist arthroscopy. Okay, that's just a 1 minute, 1.5 minute video really. There's not much to see. So basically, the actual anchors are in front of you. Please step up and have a look. The product brochure is also there. Thanks to Biotech for being the academic partners for this. And I would ask all the faculty to come forward and join us at the tables, please. Anirban is here. Hi, good to see Anirban. Anirban, please take one table. Parag, yes, Abhijit, yeah.
Thank you. So while all the delegates are getting to the tables, I would like to take a moment to acknowledge this wonderful workshop that you put together, both Shailesh and you, and especially for that last talk where you brought out all the shortcomings and the problems that we face with suture anchors. Thank you so much. Thank you.
Yes, carry on. Thank you. Let me find one person.